Hello everybody. Welcome to the next virtual Global Spine Conference. I'm more than excited, more than ever before, to host our guest, Professor Jin-Sung Kim. Dr. Luki Kim, I guess he's so experienced that you may think that he's from another galaxy, especially as he is known on Twitter as Luke Spinewalker. And today the topic is endoscopic spine surgery. What is the evidence? Where are we now? Professor Kim started with endoscopic spine surgery, he just told me, in 2006. And while the majority of spine surgeons are in their beginnings, he's able to talk about evidence while we are still in the learning curve at the beginning. And Professor Kim is a neurosurgeon. He is usually working in Seoul, in St. Mary's, but today he's able to talk from Los Angeles. Thank you, Dr. Kim, for giving us your talk, your huge experience in endoscopic spine surgery. And we are very, very happy to hear about the evidence. Where are we now?
Okay. Thank you, Alexander. Thank you for having me. Today is the conference, Virtual Global Spine Conference. I am so excited to join this virtual Global Spine conference. Yeah. I am J.S. Luke Kim, as you know, practicing at Seoul St. Mary Hospital. My hospital located in the center of the Seoul, more specifically the Gangnam area, right? So most the hot places Seoul are there. I'm gonna have the great privilege of circulating my talk with you guys across the globe through the virtual Global Spine Conference today. This is the disclosure, and as you know, I have the personal disclosure. Yeah, some of you guys know my nickname, but I'd like to highlight this one again. Dr. Luke from the Bible and another Luke from the Star Wars. Now you can call me Luke Spinewalker. Okay. Today I'm gonna address these contents below from the definition of the MIS and endoscope and current evidence and upcoming evidence and others. And okay, so the keywords today, kind of the 10 years ago and now, right? So 2009, the Dr. Mark Arts in Netherlands published this magnificent paper in JAMA, which is a randomized controlled trial between the tubular discectomy and the conventional microdiscectomy. This paper concludes that the tube resulted in less favorable outcomes. 4 years later, he published his commentary in the Spine Journal. He mentioned no high-level evidence proclaiming better result for MIS should be avoided. Interestingly, his paper and commentary eventually motivated me to move forward to pursue high-level evidence. Before 2010, when I was a junior surgeon, I think that at the podium in most of the spine meetings, I faced many challenges from surgeons who opposes MIS and endoscope. I even recorded this mindset on social media. You can find my posting 2014 and 18, thinking of writing a diary so that I wouldn't give up in the middle of this disappointed, right? It's not possible for me to walk you through all the evidence. However, you can figure out the tremendous changes in the evidence of on MIS over the last 10 years, right? So now let's see the changes of definition of MIS over time. In 2007, Dr. Alexander Bacaro, everybody knows the name of the Bacaro. In his textbook, he described the definition of MIS and mostly focusing on the amount of tissue damage. In 2019, the AOSPI MIS task force released a new definition of MIS with the following contents. It is suite of technology and dependent techniques and procedures. MIS should reduce not only local, but also systemic surgical stress. More importantly, patients have to get better outcome than traditional procedures. What I mean is that the similar or favorable is not acceptable, right? So let's move to this content on the current evidence about endoscopic discectomy, endoscopic laminotomy. When I hit the keywords, the micro and endo lumbar discectomy in 2022, 2 years ago, I found the following numbers: 223 papers on microscope since 1978. Some of you guys before born, right? More than 1,300 papers on endoscope since 1991. Just a couple of days ago, I searched again. I found a new result here. What a big difference. I'd like to bring your attention to the number of the publication about the two different skill sets. There are 49 endoscopic paper per year, what I mean, after calculation. Only 5.6 microscopic paper a year. It is almost 9 times difference, right? So, however, the problem is the quality. Just like the Dr. Mark Ott pointed this out before. There have been only 12 papers of high-level evidence so far regarding endoscopic lumbar discectomy. Only 12. Look at the list of the 12. The first randomized controlled trial was published in 1993 by Professor Michael Meyer, who brought the name of PELD. So luckily, the most recent paper, randomized controlled trial, is my paper published last year. So what about the quality of the evidence about endoscopic surgery for lumbar stenosis? This is the result of the last year. The first publication done by Citizen Written Martin Com in 2009. So the first bipolar paper was 2016. Last year, I counted it was less than 100 paper last year. The number of the related paper has increased rapidly, and now there are more than 200, sorry. However, the problem is we just have the 6th paper of a high-level evidence at the moment. This is the list of the 6th paper. It is the 2015, 9 years ago, when the Dr. Sebastian Ritten and Martin Komm in Germany published the first randomized controlled trial. Look at the journal name. It's a pain physician. It's not the spine journal, but one of the pain journal, right? Personally, I can guess probably his excellent paper was rejected by the mainstream journal. Okay, my group has a recent publication for that randomized control. So this is one of my recent case studies about the outcome following the randomized control trial between the two groups. Actually, you should be surprised. It took more than 5 years to enroll 53 patients in my hospital. Anyway, I got a result with this. Clinical outcomes were similar, but endoscope had better result related to especially radiology parameter, right? The last year, Dr. Beat in Chulalongkorn University in Bangkok had another phenomenal academic achievement. This is the first randomized controlled trial between microscope tubular versus the full endoscope unipolar decompression for spinal stenosis. So what about the upcoming high-level evidence? Is kind of you can have a glimpse of the future direction when you figure out the upcoming high-level evidence. This is one of my government-supported research grant running from 2021. So we had the 4 randomized controlled trial arms for surgical treatment of lumbar disc herniation and lumbar stenosis. The first and second trial have bipolar endoscopy, and third and fourth trial have full endoscopy for each pathology. You can catch up with the published protocol about 4 randomized controlled trial that many renowned hospitals in Korea have been involved in so far. I believe we are almost facing a time when endoscope cases for the treatment of lumbar stenosis are ramping up. In my perspective, more than 2 papers with the high-level evidence will be coming up within 5 years, probably 3 years, I think, because we almost enrolled all the patients. What about the changes of the spine community and key opinion leaders and the social platform and something like that? So let's see the expert perspective for the future. I think the governance of our society is so crucial to have a direction. Where should we are headed right now? Okay. A couple years ago, Professor Michael Meyer, the pioneer and the great mentor of the MIS and endoscope, already recorded this phenomenal perspective in the article. He called this era microendoscopic blending. He was pretty sure the endoscopic techniques would replace most of microscopic surgery. Let us hear the voice of the Professor Jeff Fang, who is the top leader of the NAS and the AO Spine and other global spine society. When I met him in 2018 and 2019 and 20 to discuss the future of the MIS, he was already sure that endoscope would become a mainstream arena of spinal surgery. What of the AO spine endoscope? In February 2018, I was invited by AO Spine to chair the first endoscopic AO Spine doubles course. As you know, the AO Spine doubles course has been a flagship training and education event. Can you see the screen well?
Yes,
no problem.
perfect.
Okay.
Perfect.
So the NAS already moved to set up this kind of the e-blending teaching material for NAS member as well. So what about the Eurospine? So I have my personal episode. And actually, when I was younger, more than 15 and 10 more than 10 years ago, I used to submit my abstract about the MRS endoscope. But every time the Eurospine, the rejected But surprisingly, last year, Eurospine reached out to me and invite the plenary speaker for addressing the endoscopy topic. So this is truly the strong evidence right now, the governance from the Eurospine, Aospine, NAS, and ISAS, a lot of the bunch of the meeting in Asia already shifted to direction to the way of MIS, especially the endoscope, right? This is the personal recap. Regarding the first generation endoscope discectomy, you're almost close to the standard of care. But I'm still not sure about the endoscope laminotomy, foraminotomy, something like the procedure, the different skill set, but it is true that about the endoscope discectomy.
And I'm really glad you liked everything.
Likewise, the founder of the Apple, I'm gonna have the one more thing, right?
But there is one more thing that I want to talk about.
My one more thing is echo chamber. Have you heard about echo chamber? So what is the definition of echo chamber? It's gonna be right kind of terminology about the musical instrument, right? But about the echo chamber, so when it is commonly used in the current era, especially we are surrounded so many the social media. Echo chamber right now is potential result in unintended exercise and in confirmation bias, right? It's kind of the echo chamber. It has a lot of the potential. It's not the positive way. The kind of the echo chamber, it can make kind of bias and fake news, reinforcement, prejudice, something like that. So what I wonder, so if you I love endoscopic spine surgery, but if the young surgeon and the surgeon only stick to the one kind of the surgical procedure itself, it means it can have kind of action of the echo chamber. We have the risk for that, prejudice reinforcement that we can face, right? So we need to see something beyond the endoscope on the spine. So Ngram is kind of it used to be most powerful searching engine before the era of the ChatGPT. Using the Ngram, it's not available since in recent days, but the Ngram, using the Ngram, you can find the accumulate data since 1050, 1500 is across the 100 years accumulate data. Look at for example, hit the keywords Beatles, Michael Jackson, and Taylor Swift, Elton John, and Mariah Carey. This is the accumulated data about that. So that is why the Beatles probably king of the singers, right? So if you hit the terminology, spine surgery, lumbar disc, and lumbar fusion, minimally invasive spine surgery, and endoscope spine surgery, something like that, look at the data. It's truly kind of the very small, extremely small percentage, right? The endoscopic spine surgery, just a small, extremely small percentage, all about among the spine-related data, right? So I'm gonna see the big picture beyond something more than, right? Because we have the risk. We don't have to trap with some specific surgical technique, right? So I love the endoscopic spine surgery, but I believe the endoscope on the spine is the best MIS at the moment. The keyword is at the moment. But however, we should accept it cannot be a panacea for every single patient. Right? Look at my description. In my practice, I perform endoscopic spine surgery, MI fusion navigation, other kind of the difficult surgery. Using the metaphor from the battle and the Roman military weapons, we need to have Fusio and Gladio and Sparta and crossbow, all of them. That is why I love to teach. I love to train my resident and fellow. You need to accept the different surgical skill set. You don't have to embrace only one skill set is endoscope, right? So that's why it's going to be my the takeaway. It is time to have the single high-level evidence-based medicine. This is the last takeaway. Thank you very much.
Thank you, Dr. Kim. May I ask you, when you look into the literature, when you look to the evidence, what will you recommend your relatives, your parents, when they have got an herniated disc feasible for any approach, whether you do it open, microdiscectomy, or tubular, or endoscopic? What will you recommend them?
So I recommend the MIS, of course, but just imagine the patient, 25 and 29 years, a healthy guy, they have the lumbar disc prolapse at level 5 or so. But actually, so Roger Hartle and I also published the benefit zone, the benefit zone of an endoscope. In case of the disc prolapse, the difference from the different skill set regarding the invasiveness is the difference is so tiny, right? That I want to say, so I can bring the interlaminar scope, I can bring the transforaminal scope, I can bring the tubular microscope, the discectomy skill set for young patient. So probably I cannot get the big difference for the patient. So that's the current thought about the endoscope. But if you are very confident of endoscope, transfer access, interlaminar access, unipolar and bipolar, either way, if one patient is coming up with your clinic, the outpatient center, if the patient has, for example, 85 years old, the diabetes and coronary artery disease and previous history of your stroke, probably even the single tiny difference between the microscope open versus transfer access, it can have the huge impact for the patient outcome especially related to the complication, right?
Yeah.
That's why we should embrace the endoscopic spine surgery for the patient.
Yeah, this was my next question. What is when the relatives are very obese? I think in my personal experience, not talking about evidence, but in personal experience, obesity is such a important condition where the endoscopic approach is it's a difference. The obese patient turns into a non-obese patient when you use it when you use the endoscope. Is there a support from the literature, because obesity is always a contraindication for any elective surgery, but in real life we have many obese patients suffering from pain. Can you give us some information? What is your
I think that's the really very different the point of perspective about the obese patient. The real value, one of the real value of the endoscope is the patient outcome the obese patient. You know, the conventional surgery, the surgical corridor is like the funnel, right? Even the microscope tube surgery, in case of the long tube, it is hard to get the perfect and the safe visualization over the surgical field. But endoscope, surgeon's eye is already spinal, over the laminar and already getting the spinal canal through the foramen. So through the endoscope, we can treat the obese patient very well with the minimal, trauma on the patient. So one of the recent tragedy story, I cannot say the surgeon's name. A couple the days ago, he texted me. He's not endo guy. So he performed the fusion surgery, postural flip surgery. The patient age is just 50, but problem is he has a huge obesity, extreme obese, the patient high BMI. During the surgery, the flip surgery, CPL happened. We don't know the cause. So a couple of days ago, the patient passed away. Yeah. So I don't know the exact role of endoscope in the high BMI patient. We have the evidence for that. One of the endo guy in Korea, he published the clinical outcome of endoscopic spine surgery in obese patients. But in Asia, so we don't have a lot of the obese patient. Likewise in United States here, right? But anyway, the high BMI and the high CCI are actually good candidate for endoscope and MI surgery. That's my perspective.
Okay, another question. When you have you're connected in a network of AO Spine, you have a good overview about where is endoscopic spine surgery performed, in which region in the world. If you have a look at the global world, I'm here in Switzerland. I may really say that from Switzerland there is no center of endoscopic spine surgery today.
Yeah.
I see countries very, very in advance, like Korea, like Thailand, like Japan, many Asian countries. Is there a reason, in your opinion, in your knowledge, why is endoscopic spine surgery so popular and so early implemented in Asian countries compared to others?
Yeah, it's an excellent question always. You know, the first endoscope generation started with the transfer axis, not interlaminar, right? So the endoscope commercially success was the Yes scope, developed by the Richard Wolf and the Anthony Young, right? It was a transfer axis that followed the conventional, the inside-out technique. So when I studied endoscope spine surgery, it means transfer endoscope, not interlaminar, right? Most the first generation, the early endosurgery, it were transfemoral endodiscectomy and foraminotomy, something like that. So we have the different cultural background, right? So most of transfemoral endosurgery in Asian patient, they accept it's not the surgery but the procedures, right? Because the procedures, we remove the disc hernia under the local anesthesia awake state, so patient can communicate with the surgeons during the surgery, right? So we actually perform the surgery, but patient recognize it's not surgery but the procedures, right? That is why one of the reasons why the transfer endoscope got popularity the 20 and the 30 years ago, right? So right now, but one of the drawback of the transfemoral access, it has a total different surgery. Even the expert guy, the renowned professors following the deformity surgery, he have to know from the bottom line if he want to do the transfemoral access, right? So also the steep learning curve. So we already have the great mentor and friends and the supervisor doing a lot of the transfer experiences, right? So we have when I started the first endosurgery 2006, I don't care any kind of the learning curve at the time, because behind me there are surgeons, big name surgeons supporting my mistake, any problem when I face it, right? So, and then second generation endoscope is kind of interlaminar access driven by the Severson Reed and other groups and the control in Korea too. And then right now is endoscope, interlaminar endoscope procedures, not only from discecting, but also the decompression is was one of the driving factors to embrace more surgeons across Asian countries, right? Some days across the day, 11 years ago, so one guy presented in Korea, presented crazy number of cases in bipolar surgery, WFNS meeting in Seoul, 2013. His name is he is now practicing in Dubai, Dr. and he is the collaborator, Dr. Son. They work together. So their presentation actually sucked the old attendee, including me, right? But actually at the time, I was a little bit against the bipolar surgery. But my gut feeling for that, why right now the many European surgeons, not only European but other across the surgeon across the globe, are actually crazy for interlaminar decompression by the bipolar and the interlaminar fusion using the bipolar, not only bipolar but also other kind of endo skill set. So because the kind of the interlaminar decompression exactly they follow the same manner standard of care of the microsurgery. It's not the transfer access in most cases. Sorry, too much talk.
No,
So
it's
yeah,
perfect, because we can only learn from the ones who use and master endoscopic spine surgery for 50 years.
my personal the gut feeling about why it is being more popular across the world. So bipolar endoscope has great contribute. So full endoscope, unipolar endoscope actually owes a lot, right,
Mhm.
about the bipolar surgery. It's kind of the action of the sinners, right? This is the many groups following the unipolar. There are a lot of the new big group of bipolar. So actually we are having the synergy effect for global, right? Standardized and global impact. Right now, the last year in the NAS meeting, one of the big meeting, the ASREX, ASREX is the company making the arthroscope, right? One of the big the company in the field of arthroscope care. They launched the endoscopic system in the NAS meeting. I believe this year too, another company followed the way of the ASREX, probably the bipolar and the something like the unipolar either way. So now, so we have the crazy number of the evidence. The society started to embrace the endoscope surgery. eospine and NAS and the ISS and the urospine. And then right now, company are moving, right? Industry are moving to support to push the endoscope to treat the patient, because there's some factors behind the screen, right? So company always follow the capital, right? In United States here, so without ASC, so it's a so crucial impact whether the surgeons embrace specific technique A or B. The endoscope is a great tool for AS center, right?
Yeah.
So many in the industry are developing the instruments for supporting the ambulatory spine care.
Yeah.
Yeah.
Lucky, may I just one question? You introduced endoscopic spine surgery in your institution. Where did you learn? Who is your teacher? Because
Yeah.
we are sometimes a lack of teachers here in Switzerland, where to go to. And I know many in the audience do endoscopic spine surgery, and everybody has had a fellowship or any course. But in 2006, when you started with endoscopic spine surgery, the concentration of teachers was far lower than today.
So I'm very happy to have a comment my teacher's name. So in 2006 and 7 and 8, so I had the great mentors. One of the At the time, the university hospital in Korea, they never accept endoscopic surgery. Only one or two, a couple of centers, they rarely do the endoscopic spine surgery, including the professor. My mentors there at the time, they worked there together. Urido Spine Hospital. Urido Hospital is one of the biggest private spine center. As far as I remember, every single day, we had the one hospital at the Seoul Cheongdam located. The crazy number of the surgical cases, more than annually. I'm not sure the exact number. For me, I operate at least 405 up to more than the 500 per year. Among the cases, almost the 30% and 40% were endoscopic discectomy, decompression. So I had the teacher, the Gon Choi, and I had the teacher named Hoyeon Lee, and I had teacher of the Dr. Byung-Ju Chung. So probably you are familiar with the name of the Gon Choi. He used to be very active teaching the transforaminal and interlaminar discectomy 15 years ago across the globe, right? So I had the great teachers. Also, we have interacted very well. I have the many friends working together. Yeah, one of the guy. So yeah, a lot. Yeah.
Yeah.
I was
So
very lucky at the time.
So very, very good. Is the fusion rate in your institution dropping because
Dropping
of
down. Yeah,
it's not
it's true.
dropping,
Yeah.
or is it dropping?
Because the personal opinion of the principle, the basic and the phenomenal role of endoscope is decompression. So decompression. So because of perfect, the beautiful, the structure say the decompression, it might have the effect of cannibalism. So once the endoscope cases, especially for aminotomy, right? For aminotomy cases of the foraminotomy is growing up. The other way, the number of the inner fusion is getting down. That's why the industry, they were not interested in endoscopic spine surgery before. But recent days, many my friends and international colleagues, they have developed the skill set. So how they fuse better than the conventional, the innovative method, right? So company are interested, oh, this endoscope has a great performance for innovative fusion, right?
Yeah. Um, the I think it's very popular if you promote procedure that avoids fusion. You will get applause from every side, I guess, in Eurospine, in NAS, everywhere. Um, do you think that endoscopic spine surgery is just postponing the fusion surgery, or is this replacing the fusion surgery?
So one of the topic last year, I commonly addressed the topics. How's the role impact of the endoscopic uh, on the spinal disease pathway? So, the spinal disease never happen once in our whole lifetime, right? In mid-20s, some patients have the disc herniation, and 10 years later, vacuum disc and foraminal stenosis, and a couple years later, the spondylolisthesis happens, something like that. This is the natural course of the spinal disease pathway. The role of endoscope on the natural pathway, right?
Mhm.
So we can postpone the kind of right? How can I say, postpone the clock, life
Yeah.
clock, right? So the little chance, the increasing number of the fusion instrumentation, it probably increase the risk of the complication as well. So if you are capable of decreasing the pathway and eventually postpone the instability, so we can save the money, we can make the patient happy, but I'm not sure the company do like that. But anyway, I believe that's the way we have to go further, right?
Yeah, I think it too. It's a commitment for the patient. Um, so Professor Kim, Luki, thank you very much. It was a great talk, and I really must say again that talking to a so experienced specialist is really rare. I'm honored that you have taken my invitation. Endoscopic spine surgery, for sure, as you've mentioned, is a topic for the future, and the rate and the amount of procedures that will be performed endoscopically will rise. We are witnessing right now here in my country a tremendous rise of centers who introduce endoscopic spine surgery into their routine. Um, and I guess visiting a specialist in Korea is always an option. Are there fellowships? Are there possibilities to visit centers in Seoul in your institution?
It's a little bit complicated for me. I don't have any spaces up to the end of 2026.
Okay, so we have to
So
we
I
have to
can I
book.
can recommend our big name surgeon for you guys too.
You know, but it's as you mentioned, AO Spine does really good, offering courses in Davos every year, and it's an opportunity to meet you. Um, thank you very much. I
Pleasure.
think the take home message is we need these high level evidence, and as you have shown, they will come to us in the next 5 years. So the time of skepticism and criticism will be answered with the evidence-based medicine again, like in many other fields. Thank you, Luki. And next week, it's again a talk about endoscopic spine surgery.
Great.
Dr. Huang will be our guest, and Dr. Dalada will host him. And thank you very much for your talk, and thank you very much for the auditorium, for the participants that you joined us. It was a high number of more than 40 live participants, and thank you very much. And good night, or good afternoon, or good evening, wherever you are. And I say goodbye, and see you
Thank
in
you.
June. See you in June
Yeah,
here in
sure,
Switzerland,
sure.
Luki.
Thank you. Thank you very much.
I'm looking forward.
Great. Stay in the loop. Goodbye, everybody.
Bye.